Dear friends, it's a pleasure to be here, and you may ask yourself what on earth has compartments to do with venous insufficiency. Well, we have discussed pathophysiology, and this is just a repetition of what is happening, and we can go over this very rapidly, but finally we end up with a chronic venous insufficiency with limb swelling, skin changes, and venous ulcer disease. In patients that develop lipodermatosclerosis, we have an affection directly on the skin because the skin becomes inelastic, and that may have an impact on subcutaneous and subfascial structures as well, which may have an impact on tissue pressures and thus compromise the skin circulation. As we know, we have several compartments, and what is most well known is the intramuscular compartment, which is limited by firm structures at the fascia and bones. But in the situation where we have lipodermatosclerosis and stiff skin, we also could talk about the subcutaneous compartment, which is limited by the thickened fascias and the skin that is now non-elastic. Treatment of venous ulcers, of course, we know of all this: adequate compression therapy, pharmacological therapy, and eradication of superficial reflux by ligature removal or obliteration. In a recent study, we measured, because we were interested in what happened in these compartments in patients with C5 and C6, and we measured tissue pressures in the subcutaneous and in the intramuscular tissues. And we found that in advanced chronic venous insufficiency, with patients with chronic venous ulcers or recurrent ulcers, there were significant increased tissue pressures in these compartments compared to the healthy normal limbs. And here you can see it. You can see the intramuscular pressure, the subcutaneous pressure, and the tissue oxygenation around the ulcer area. And you can see that we are in a situation where intramuscular tissue pressures may reach as high as we are reaching the level of acute compartment syndrome. And we have also an increase in the subcutaneous tissue, and you can see that the oxygenation around the ulcer is severely decreased, and with the literature we use from the orthopedic surgeons, they usually say if you have a pressure oxygen tension that is less than 20 millimeter mercury, you will have poor ulcer healing, poor healing. We have measured the tissue pressures or the compartment pressures in the posterior superficial compartment and in the anterior compartment. We have also measured subcutaneous and intramuscular tissue pressures in limbs with various venous pathologies and particularly severity, to evaluate if there is a relationship between different venous pathologies and their severity on the tissue pressures. And here you can see we have, in principle, 6 groups. We have the number of limbs in the different groups according to the C classification. And all the patients had normal ankle brachial index and palpable arterial foot pulses, and the tissue pressure measurements were performed with the patient in a standing position in the non-weight-bearing limb. We have evaluated the proximal venous system only with duplex ultrasound, and we know that we may have missed out some lesions in the proximal part. And this is what we found. Here is the subcutaneous tissue pressures, which are low, often negative, in the subcutaneous compartment. But as the disease increases, according to the C class, the pressure increases significantly. And so, in conclusion of that, you can say that the worse the clinical score was, the higher was the subcutaneous tissue pressure. And that was also true for the intramuscular tissue pressures. And here you have the numbers, and here you have the progression with the worsening of the disease with get higher intramuscular tissue pressure. We didn't find any tissue pressure differences between the anterior tibial and the two intramuscular compartments. Superficial and deep reflux had higher pressures than superficial reflux alone. The importance of the fascia, because if we don't have a thickened and stiff fascia, we would probably not increase the pressures the way we have seen. It's not a new concept. It was described already in the beginning of 1900s, where Gondeleon did lateral skin incisions and resection of strips of the fascia, including the super-adjacent dermal tissue. Linton's procedure is well known to everybody as well. The problem with these two interventions was long operating time, extensive tissue trauma, because don't forget that the skin is in a very bad condition, so you had healing problems within the unhealthy skin. In the 80s, Professor Haag in Germany started to use paratibial subcutaneous fasciotomy for these patients, which we have applied to avoid the drawbacks, because here you make a small skin incision in healthy tissue way away from where you have the ulcer. And then you make a small incision in the fascia, you take a long Metzenbaum scissor, and you slit the fascia open all the way so that you actually can see the scissor under the ulcer. If you stay very close to the bone, you avoid vascular and lymphatic lesions, and that is a very important issue. Very, very rarely we have had to use drains for minor bleedings, because obviously you will, during this procedure, cut one or two small perforating veins that may bleed. We do post-operative compression, of course. And here you can see what happens when you have done the subcutaneous fasciotomy. All these patients had simultaneous, if needed, superficial obliteration, either with surgery or with endovenous procedures if they had a superficial incompetence. Big perforators, as defined by the American Venous Forum, were also ligated at the same time. You can see that there is a dramatic decrease in the intramuscular pressures, the subcutaneous intramuscular pressures, and this improvement stays and actually even improves as long as up to 3 months after the procedure. Same thing was true for the subcutaneous tissue pressures that normalized over the time after the subcutaneous fasciotomy. Transcutaneous oxygen tension increased, and this was the reason why all these patients had a very rapid ulcer healing, all of them. And this was, and don't forget, these were patients that had recurrent venous ulcers that had a long time of trying to heal the ulcers with conservative treatment previous. There is a difference in ulcer healing if you compare the post-thrombotic patients with the patients with primary disease, which is not unexpected because you have deep venous involvement. What happens after time? Well, here in this slide we have the follow-up up to 3 years. We are now up to 6 years, and it stays like this. You can see that you have a recurrence rate totally of 11%. But when we look over time, the post-thrombotic patients with ulcers have a higher risk of recurrence than the others. Those patients who recovered, interestingly enough, was remeasured in their compartments, finding that they have increased their compartment pressures, and when we reoperated a couple of these patients, we saw that the fasciotomy that we have done had now closed with fibrous tissue, and we did a fasciotomy for these patients, and that solved the problem. So in conclusion, severe chronic venous insufficiency with therapy-resistant ulcers has significantly increased tissue pressures compared to normal limbs, and significantly lowered transcutaneous oxygen tension near the venous ulcer. Post-thrombotic limbs have significantly higher intramuscular pressures, compared to patients with only superficial reflux. Eradication of all superficial reflux decreased subcutaneous tissue pressure significantly, but did not change very much the intramuscular tissue pressure, but increased the oxygen tension. Additional subcutaneous fasciotomy instantly and significantly lowered the intramuscular and the subcutaneous tissue in both post-thrombotic and primary chronic venous insufficiency patients. And it increased the oxygen tension, which in my mind was the reason why it promotes a rapid healing of this therapy-resistant chronic and recurrent venous ulcers. Subcutaneous tissue pressures are significantly elevated in limbs with symptomatic varicose veins and increase with disease severity, and intramuscular tissue pressure are highest in obstructive venous disease. And very high intramuscular tissue pressures are also seen in C5, C6 limbs in both primary and secondary disease, most importantly though in the post-thrombotic limb. So adding to Peter's algorithm paradigm, I think what this is reserved for is a very small group of patients with ulcers that are very difficult to heal, and I would recommend that you measure the pressures, and if the compartment pressures are high, there is an indication to do a subcutaneous fasciotomy, which is a simple operation and without major complications. Thank you very much.